Yes, thank you so much. And I'm going to pick up right where Senator Warner left off, because several years ago I developed what's the Rural Health Agenda. It was important for my state of Tennessee. And Senator Durbin and I have worked together on workforce and have legislation that would beef up that workforce. As you mentioned earlier, Ms., is it Redfield? Getting people to work in a rural area. So if you do this for a period of 5 years, then your loans would be forgiven, your student loans would be forgiven tax-free. And so Senator Durbin and I are working on that. Senator Hickenlooper and I are working on innovative delivery models so that you carry that access into the rural areas. And as Senator Warner said, he and I have worked on this area wage index. You know, having these differentiations made sense in 1968. They don't make sense today. Healthcare delivery is technology. I'm reminded of this as I go through my community every day with healthcare innovators that are there in Nashville. I do want to talk, let's see, Mr. Davis, let me talk with you about telehealth, because this is something, when I was in the House, we worked on telehealth, and we have seen tremendous promise with this. I think we've got 90% of the healthcare centers are now offering this, and of course, we decoupled it from the emergency health order. Permanency is going to be important. Stopping this thing of having to go back and reauthorize is going to be important too. But the disparity in the reimbursements, our rural centers are getting $95 for a telehealth visit. Urban and in-person visits are $195. Now, we know this is expanding. I recently went through the technology that is, the doctor is a hologram, it's in the box, it's in the room with the patient. So that's the next evolution of this. So talk to me about the difference in reimbursement rates from the telehealth to the in-person, the way you get better compliance with adding in the telehealth, and the difference that makes for people in rural areas.
Sure. That's a great question, and I think you kind of bring up a great point. I think we're at an inflection point in this country where we've been advancing telehealth, and then the pandemic hit, and we really saw a lot of providers and patients who actually learned to love it, where they were really reluctant to use it prior to, and now they don't want to go back. They see it as a great tool to improve access, and really for some of those patients that are really hard to get in. They have transportation issues, they have mobility challenges, they're busy, maybe they're working professionals, so to be able to leverage technology is huge, but there's a misaligned incentive whereby these rural health clinics and FQHCs, we don't get the equal payment, and so it's to our advantage for those who run these clinics to prioritize and prefer and almost push these patients to come in for a visit. And so absolutely anything that we can do to increase that payment parity. You know, for us, we have a couple rural health clinics, and we have to carve out any space in the building that is being used for telemedicine. We can't recoup those costs, which to me, it shouldn't matter whether we're rendering that service via a camera or a microphone or whether in person. We're taking care of rural Americans, and therefore the payment should be on par.
Well, I agree with that, and the area wage index, I want to add just one more thing on this in the work that Senator Warner and I are doing, trying to establish that floor and get it at an 85% floor, because technology is where it is now, and we have to make certain that you preserve that access to care in these rural areas. And unless we address this wage index, we're not going to be able to guarantee that.